You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. This is the second in a series of 3 podcasts where we'll go over the most high-yield overdoses found in children. Continuing with the Goldilocks format, today the porridge is just too cold. Patients who are critically ill often come in with little to no information or context. We try to identify toxidromes, but they can overlap. Today we'll talk about the toxic presentations that cause psychomotor depression, or a depression in vital signs, like the cholinergics, sedative hypnotics, cardiovascular medication overdoses, and opioid overdoses. If we keep rummaging through the Three Bears cottage, we might just find out how low we can go. Medics are bringing in a 10-month-old who got into his brother's vape pen, also called a wax pen, vaporizer, dab pen, vapor pen, or pen vaporizer. The child arrives and medics have little information. When they found him, he was crying, restless, and wouldn't keep still. Now he's lying down in the gurney, on his side, listless, covered in vomit. His diaper is full of stool. Now, pretty much anything can be smoked or vaped nowadays, so we shouldn't assume it's nicotine. Except, well, here we have a pretty great example of it. Nicotine is the model dynamic overdose, calling for a dynamic resuscitation. It has to do with what receptors are saturated at what point in time. Is it more yin or more yang? Just to back up, your skeletal muscle uses acetylcholine only as its sole neurotransmitter. There are no ganglia involved. It's a straight shot along the wiring from the CNS to the skeletal muscle. Pretty easy. In fact, acetylcholine is always the base neurotransmitter. If there's only one part of the chain, it's always that first part. In skeletal muscle, it's the first and only step. In the autonomic system, which of course includes sympathetic and parasympathetic wiring, we have a chain of transmitters. Whatever the flavor, acetylcholine is always the first step in both sympathetic and parasympathetic pathways. The first synapse is the nicotinic receptor powered by acetylcholine. Now this is where it gets interesting. The sympathetic and parasympathetic systems need ganglia to keep their infamous balance of yin and yang. You can't live in a state of only fight or only relax. In the fight or flight pathway, the sympathetic nervous system, we start with acetylcholine at the nicotinic receptor, and the subsequent synapse down the line is norepinephrine. No surprise there. When we overstimulate the first step in the chain, the acetylcholine nicotinic receptors, we get the usual MTWTHF, the Monday, Tuesday, Wednesday, Thursday, Friday symptoms, muscle cramps, tachycardia, weakness, twitching, and fasciculations. Monday, Tuesday, Wednesday, Thursday, Friday, way to remember. The jitteriness that comes from just a little too much cigarettes and coffee. And that's only the first link in the chain. The second step, mediated by norepinephrine, augments this excited state. That's all well and good. If you overwhelm that system, the fight or flight system, you can have spillover to the harder to reach receptors, the parasympathetic. It makes sense. The sympathetic system is very accessible, very easy to activate, probably as a protective mechanism for us. It's so much harder to access your parasympathetic, the rest and relax system. I think all of us in medicine can relate to that. Anyway, in a nicotine overdose, you get first a lot of the sympathetic effects, tachycardia, twitching, fasciculations, until you overwhelm that system and overflow into the system that is usually harder to stimulate. But now it has an overflow of nicotine acetylcholine cannonballs to hit it hard. After that rush of sympathetic, the parasympathetic gets involved. As we mentioned, the first neurotransmitter for parasympathetic is acetylcholine, and the last is acetylcholine. The parasympathetic end receptor is the elusive and fascinating muscarinic receptor. We don't talk much about muscarinic receptors because it's hard to take that much of a cholinergic agent to flood all of your other receptors and finally get to the muscarinic response. But the muscarinic receptor is pretty powerful in its own right. All aboard, last stop, muscarinic receptors, and you get all of the wet, sludgy signs. In fact, one mnemonic is sludge for the cholinergic syndrome, but probably more clinically relevant are the dumbbells: diarrhea, urination, meiosis, bradycardia, bronchorrhea, bronchospasm, BP so low, emesis, lacrimation, and salivation. When you see someone who's been poisoned, they are all sludgy or dumbbelly. You know that their whole autonomic system has to be overwhelmed, and they are actively dying. They're drowning in their own secretions. They're becoming bradycardic. Adults can tolerate hypoxia and bradycardia amazingly well for a short period of time, but children can die this way. So, receptor junction, what's your function? It's fantastic if you remember all of that cool wiring, but at the bedside in front of your little sick patient, let's keep the concept simple. It's like gambling. In a nicotine overdose, you gamble it all. You throw all of your money on the table for that fleeting moment that you're excited to win, but soon you're left depressed and with nothing. Nicotine overwhelms you, and you're left with a wet, bradycardic, drowning in your secretions, fluid coming out of both ends kind of wreck. That, my friend, is your intro into the cholinergic syndrome. Sludge, if you like: salivation, lacrimation, urination, diarrhea, GI upset, and emesis. Or even better, an updated version: dumbbells, diarrhea, urination, meiosis, bradycardia, bronchorrhea, bronchospasm, BP so low, emesis, lacrimation, and salivation. Nicotine, as you can see, is a dirty overdose. It hits a bunch of non-related receptors, but it ends up with a muscarinic-flavored cholinergic predominance. Approximately 1 mg per kg is the often cited lethal dose. Nicotine is there for your destruction in gum form, nasal spray, lozenges, patches, and of course now in ultra-concentrated liquid for vaping. The liquid nicotine vaping solutions can vary from 20 mg per ml to 100 mg per ml of nicotine. So really, any ingestion is certainly worrisome and can be fatal. The classic cholinergic syndrome is seen in old organophosphate pesticides that sometimes little ones can still find lying around, like malathion. Or it can also be found after chemical warfare agents like sarin. Don't be fooled, though. You're more likely to see it after an overdose of common meds like ipratropium in all ages, or getting into grandpa's urinary frequency or dementia meds. The point is, always look up the actual compound that the child could have ingested. Well, what do? If you have more of the usual symptoms, the earlier or lower overdose symptoms, muscle cramps, tachycardia, weakness, twitching, fasciculations, then treat all of that excitation with benzos. And watch them carefully to make sure that the toxicologic trajectory doesn't look more like an overflooded nicotinic now spilling over to muscarinic, sludgy dumbbells. Diarrhea, urination, meiosis, bradycardia, bronchorrhea, bronchospasm, BP so low, emesis, lacrimation, and salivation. What are the life threats here? Not the diarrhea or even the relative bradycardia per se, it's the bronchorrhea. You can literally drown in your own secretions here. This is an important concept to remember because the antidote you give is not to fix the bradycardia, but to clear up the secretions. If this is a chemical warfare event, you surprisingly may be given 2-PAM, but that's stocked only in prime sites throughout the country. 2-pyridine aldoxime methyl chloride or pralidoxime is really only helpful in organophosphate toxicity. It will relieve neuromuscular weakness, including weakness of the diaphragm. It's awesome. It helps to regenerate cholinesterase to mop up the synapses from too much acetylcholine floating around. It comes as an auto-injector, and you can use it right in that vastus lateralis muscle. Well, we usually don't have 2-PAM lying around, but we do have atropine at the ready, and it's always a good start. Atropine works directly on muscarinic receptors to combat all of the wet sludge. Remember, at baseline, too much atropine and you get an anticholinergic syndrome. So we're trying to get more yang and less yin. We're trying to dry up the patient drowning in his secretions. You will have to give massive doses. What's the PALS dose of atropine in, say, AV block, causing bradycardia and poor perfusion? 0.02 mg per kg. So we give, 0.5 mgs, 1 mg? If you need to clear up that bronchorrhea, you're giving 1 milligram, 2 milligram, 3 milligram, more and more until that child can breathe. So the cholinergic crisis can be scary. If you see the dumbbells, keep that child's secretions under control. For everything else, there's a benzo for that. You get a call over the radio that the medics are bringing in a 14-year-old boy with a calcium channel ingestion. That's all you get. No other information. All they have to report now is a BP of 90/60, heart rate 70, and they'll be there shortly. Now, these kinds of meds can get bad real fast. There is nothing worse for us to deal with than a bradycardic hypotensive patient. Hypotensive and tachycardic, well, at least you've got a compensatory response. Maybe he needs fluids, maybe he needs more squeeze. Bradycardic, normotensive, that's cool. The periphery is compensating by clamping down. Just stay right where you are, maybe some atropine, maybe some pacing, we got this. Hypotensive, bradycardic, no help with any compensatory process. If you don't address the cause, your patient's going down. You assemble the troops and assign roles. In a calcium channel blocker overdose, you can give, more calcium in the form of calcium gluconate or calcium chloride. Maybe even some high-dose insulin and glucose therapy, or even lipid emulsion to bind the drug. Just as you're clear on the plan, the patient arrives. He's somnolent. He smells of vomit. You ask for a blood sugar. In the field, they got it. It's 65. Okay. His skin signs are slightly cool, but that may be from the water that was poured on him. Something doesn't add up. What were the meds again? The medic just repeats what he was told, but he wasn't told which one they were talking about. He talked to the aunt, who is on her way. Auntie arrives right after, and she's distraught. You try to find out what the med was. She can't say. You go down your list to see if something sounds familiar. Too upset. She asks if you can check her out. She says she's feeling real bad herself now. Yes, of course, but just stick with me for just a moment. About your nephew again. Just a few questions. You're doing okay. You confirm that he is 14, and she adds that he's been feeling isolated from friends. He's not doing well in school. His single mother works a lot. The boy was staying at her house for the weekend to try to cheer him up a little bit. The aunt then found him stumbling in the hallway with glazed eyes. He falls to the floor. She calls for an ambulance, pours water on him, tries to get him to stand up. You try to get back to the issue. What meds could it have been? You try again. She remembers. Carvedilol. Auntie has early onset heart failure. Okay, you think Carvedilol, that's a beta blocker, not a calcium channel blocker. Sometimes adults with heart failure are on both meds, but any other meds, digoxin, anything? No, she doesn't think so. Did he overdose on his auntie's beta blocker, the Carvedilol? Why did the medics say calcium channel? Is there something else? How can we reframe this presentation to try to figure out what our priorities are and what makes sense? We have a young man here who is hypotensive and bradycardic. So not many things can do that. Either calcium channel blockers or beta blockers. Of course, clonidine can do that. But one trick, in the bradycardic hypotensive patient who's altered, look at those pupils. Are they tiny? Is his sugar okay? Then it's clonidine. In this case, though, what are the likely culprits? Calcium channel blocker or beta blocker? Here's a relatively easy way to help distinguish them on presentation. Beta blockers often cause a depressed level of consciousness in an overdose. In fact, mild psychomotor depressive symptoms are a common complaint when someone starts a beta blocker at baseline. Also, beta blockers tend to give a relative hypoglycemia through the same cyclic AMP transport mechanism that causes all of the other symptoms. Calcium channel blockers, on the other hand, tend to cause a relative hyperglycemia and no change in mental status. So back to this child. We know that both agents are low and slow, but beta blockers are bitter and batty, hypoglycemia and altered. Calcium channel blockers are calm like candy. Beta blockers bitter, calcium channel blockers candy. You may be thinking, charcoal. If the ingestion happened within a relatively short time frame and the patient's awake, then go for it. The time frame for activated charcoal to be given is usually within an hour, only because after that, a good amount of the drug that was ingested has already been absorbed and charcoal won't do very much. Now, have I given activated charcoal at 1.5 hours, at 2 hours? Of course. It's also recommended to give anytime there's a massive overdose, so I try not to split hairs on this one. Just make sure that you're giving activated charcoal for the right overdose. It works by adsorbing itself to the agent. It works on most prescription drugs that have a complex molecular structure. Activated charcoal doesn't really have any effect on metals. So an iron overdose? Nope. Lithium? Nope. Alcohols? No. Similar to that, caustic substances like drain cleaners, activated charcoal doesn't do anything. Now, our boy is past that. He's too somnolent, and who knows when the ingestion occurred. You have good IV access. It turns out the treatment for both calcium channel blocker overdose and beta blocker overdose is the same, really. I know, I kept you in suspense working through all this, but it was worth it, right? We had good data on calcium channel blockers in the past, and so we started using that treatment for beta blockers, and we, as a medical community, realized that the standard approach actually works for both. Calcium itself is a mild vasopressor in everyone, so that's helpful. It will also aid in inotropy, more squeeze of the heart in either overdose. Okay, so far so good. Glucagon aids in cyclic AMP augmentation, allowing for more intracellular calcium. So that's good too. You can give some calcium in the blood, and glucagon helps to get it into the cells. There, it's used to increase contractility in smooth muscle and the heart. If the overdose is severe, you may want to push the metabolism further by using high-dose insulin and glucose therapy. You start glucose, and you want to keep them a little hyperglycemic. You continue the infusion and give a bolus of 1 unit per kilo regular insulin, followed by continuing glucose infusion at 0.5 units per kilogram per hour of regular insulin. When you do this, of course, you have to be very, very careful that another favorite electrolyte is not neglected. Our buddy, potassium. Make sure to look up the doses and take your time on this one. Another option for severe poisoning of either beta blocker or calcium channel blocker is lipid emulsion therapy. They're the same fats that we use in TPN, but in this case, we use them to bind and neutralize the drug. Another use for lipid emulsion therapy you might be familiar with is for its use in LAST, local anesthetic systemic toxicity. That's why we calculate the dose of local anesthetics before we infiltrate those wounds. The main message here in calcium channel blockade or beta blockade is this. These patients can decompensate right in front of you, so be aggressive with your supportive care and give calcium gluconate through a peripheral IV, chloride if needed, and quickly step up the treatment as you can to glucagon, high-dose insulin and glucose, and maybe even lipid emulsion therapy. Support with vasopressors if needed. Remember, atropine and IV fluids won't do very much in this case. Always be ready for the next step, and you won't get stepped on. There's trouble afoot at the local middle school. One of the whippersnappers over there decided to bring in some Xanny bars for fun times at recess. The patient's father takes Xanax or alprazolam semi-recreationally, and now a quarter of the 7th grade class has had the same pleasure. You get a call that medics are bringing in 7 children who are all stoned. Great. You get your staff together, ready for criticals. 2 of them arrive altered, the rest just, sloppy. The sickest is the 12-year-old mastermind. He's stuporous, but maintaining his airway, except when he flexes his neck, he has sonorous respirations. He dips down to 93%. You reposition him, head of the bed up, towel roll under his shoulders to align his airway axes. You do a quick head to toe. There's no trauma, there's no rashes. His vitals are blood pressure 96/60, heart rate 62, respiratory rate 10, and his O2 sat is better now with just a little repositioning. Overdose with benzodiazepines is the perfect paradigm for supportive care. Yes, the porridge here is too cold. Very cold. Not much is bubbling, boiling in that noodle of his right now. The main decisions are these. What is the trajectory of illness? And if I walked away from the bedside and left him there for a few minutes, how would he do? In the field, he was stuporous, and it looks like our ringleader was a bit bolder in his dose today than his followers were. With simple repositioning, our troubled tween did better. One option, of course, is as a safety mechanism, we can insert a nasopharyngeal airway. To size it correctly, you measure it against the patient's cheek. The flange is at the nares, and the end of the tube should reach the tragus. Make sure it's not too huge or too small. Each will have its own issues. Lube it up, and always bevel to the nasal septum. So that means the flat edge of the NP airway, the opening, glides along the medial aspect of the nares, along the septum. If you're inserting into the right nares, then the natural curve of the NP airway is already facing down. If you have to insert the nasopharyngeal airway into the left nares for whatever reason, maybe there's a deviated septum or you're placing bilateral NP airways in a sick patient because you're bagging them, on the left, you'll still use bevel to septum, but of course the NP airway is going to be facing up towards the sky, so a third of the way in, you'll just twizzle it, clear those turbinates. Otherwise, you end up having a turbinate biopsy. Make sure bevels towards the septum and twizzle if you need to on the left. You place a nice NP airway measured nares to tragus, and he just does not care about your sticking a rubber hose down his nose. But that's okay. It'll help to keep his airway open, and when he's awake enough to care or gag, he'll just pull it right out himself. This works really well also for school-age children and older children who are altered after a seizure. They're no longer seizing, but they're snoring. You don't want to place an ET tube because you feel that phase really should be short-lived, but you want to have a little extra security. That NP airway is your go-to. All right, back to our friend. He's a bit better with your NP airway, and you do a full screen of other ingestants like aspirin or acetaminophen. Who knows what his intentions were at the time? Probably just to make social studies more interesting. In the sedative hypnotic toxidrome, everything is depressed. Heart rate, blood pressure, respiratory rate, and level of consciousness. Pupils can be anything depending on the agent. We're talking alcohol, benzos, barbiturates, GHB, Rohypnol, baclofen, soma, and all the things that make you one cool cat. Except now you're here and I'm trying not to overreact to you. In the sedative hypnotic toxidrome, you'll see ataxia, confusion, hallucinations, then just depressed level of consciousness, along with all the other depressed vital signs we talked about. And it's all supportive. What? What's that? Flumazenil? Are you kidding me? Okay, give me a second. I'll be okay. Why do we avoid flumazenil like the plague? I mean, why don't we just reverse the sedative? That's all well and good if you are an anesthesiologist and you have a happy, healthy patient to whom you yourself just gave a little too much twilight nappy time medicine and you want to get him recovered now because the next patient's coming into the OR. The key here is the known time frame. If you have someone who is benzodiazepine naive and you yourself gave too much benzo, then sure, theoretically you can block the GABA receptors and wake them on up. In the ED, flumazenil is never really the answer. You never know how exposed the patient had been or dependent on that medication or really anything. The danger is that you have someone who is used to taking benzos, his GABA receptors are all upregulated, and he needs a certain level of GABA activity to prevent seizures. It's the same idea that bad alcoholics need that drink or they go into withdrawal. Flumazenil will precipitate acute GABA-like withdrawal on the chronic user, and those seizures are so hard to treat because, well, you can't give them any more benzos. You've burned that bridge. So, no flumazenil for you. We're just going to have to watch him like a hawk. And then there's social work and talking to the parents and reassessing and probably involving the school and reporting and reassessment and documentation and maybe admitting and reassessment and more charting and reassessment and more phone calls and more social work and more reassessment. It's 2 a.m. A 15-year-old girl is dropped off by her friends. She's disheveled in a party dress. She has vomit all over her hair and is completely out of it. She doesn't respond to painful stimuli. You get her on the gurney. She, too, has been eating the cold porridge. Everything is down, but most markedly, her respiratory rate is 6. No, really, you reposition her and you count. Every 10 seconds, she takes another slow breath. Too slow. Her O2 SAT is still okay at 96%. You do a quick body check and everything else seems all right. There's no trauma. Her clothes aren't torn. She still has her underwear on. You get IV access. You try to get collateral, but her buddies are long gone. The nurse asks, "What about some Narcan?" And you say to yourself, "Self, when do I give Narcan?" There is a simple answer and there is a more involved answer. The simple one is if there's a dangerous physiologic derangement like apnea or peri-arrest or arrest, then yes, give it. That is the recommendation from the American Heart Association. So give it to those for whom you are performing CPR. Now, that's a pretty obvious indication, but it sets the stage for when we should use it. respiratory, depression, apnea, arrest. But then that brings us to the more complex answer. Other than the critically ill, sometimes we give it and sometimes we wait. Well, why would you wait? Let's do this, right? Okay, but let me bring you into a world where Narcan can make things worse. I'm not talking about pre-hospitally or as a harm reduction strategy. An easy scenario is in the ED. You see a patient with opioid dependence who maybe just went a little too far and he's scooped up by EMS, brought to you. He's breathing slowly but is oxygenating okay, and we think he's ventilating okay. If you give this man a large dose of naloxone, he will hate you with the intensity of 100 suns and listen to nothing you have to say. Then he will bolt. What was the half-life of Narcan again? Maybe 30 minutes? What's the half-life of whatever opioid he dabbled in? Who knows, but it's probably longer than that, which means that gives him just enough time to get far enough away from you, down the street, only to succumb to the effects of the opioid overdose all over again, except this time he's probably hiding himself somewhere, maybe never to be found. So our goal is not to reverse the opioid in its entirety. You will precipitate withdrawal. The goal is to titrate to a pulse, or titrate to a respiratory rate, or titrate to some oxygen saturation that is safe. Other than that, the safest thing to do is to give other supportive measures and monitor this patient. The other danger of too aggressive an approach with naloxone is that if you give large doses, especially repeat large doses, you block any natural endorphins in the body and you can precipitate a hypertensive crisis. In this 16-year-old, you would probably just make her vomit, jittery, and send her BP to 220/120 and her heart rate into the 120s. And with any luck, that's fleeting, we hope. In the child with comorbidities or the older patient, we can give them cardiac ischemia or a hemorrhagic stroke. Just be careful, be mindful. Remember, Narcan is not to reverse intoxication. Narcan is titrated to support respiration and cardiac output. We don't give Narcan for the mental status boost. We give it to patients so they can breathe. A young mother brings in her 10-month-old for vomiting and fussiness this afternoon. No fevers, no diarrhea. She had her finger foods today earlier without complaint. Normal number of diapers. You're rolling along with a very bland history here. Any other medical problems? No. You aren't really sure about her work of breathing when she comes in, and so you follow your own personal rule. Get the kid naked. You lift up her onesie to take a look at her chest so you can really see what's going on with her work of breathing, and there's a sternotomy scar. You brace yourself and make sure your tone is welcoming and supportive. Where's the scar from? He had surgery. Yes. What kind of surgery? His heart. She looks at you like you're the dumbest kind of dumb for asking that. You can see that you're coming at the question from two very different perspectives. Mama is very concrete. That's okay. Let's adjust. After some questioning, you realize that the little one had a very large VSD that required open repair and has had some residual congestive symptoms. Mother responded the way she did because of the way that we asked the question. There are no medical problems now. They're all being treated with medications. Anyway, the punchline is that the child is on digoxin. His pediatric cardiologist just changed the dose, and mother was using the dropper from the old bottle for the new medication. Digoxin in children is finely tuned by ideal body weight and creatinine clearance, and very small dosage changes require accurate measurements in the oral solution. Mom was doing the best she could, but she was throwing a little bit of a curveball there. The baby looks tired and a little volume down from the vomiting. Let's get her on the monitor. Her heart rate is 70, which, of course, for a 10-month-old is terrible. The perfusion seems okay from her skin signs, except her general appearance is screaming, "Get me stabilized." We have to act now. Digoxin-specific antibody fragments are needed to mop up and neutralize the digoxin that is poisoning this child's heart. You'll see a wide variety of dysrhythmias in digoxin overdose: tachydysrhythmias, bradycardia, block, bigeminy. 3 important things about digoxin toxicity. If the patient is on digoxin and they come to you with anything other than, "I have an ingrown toenail," you probably want to know their digoxin level. It probably does affect what you're going to do for them. Second, you have to know the patient's potassium. Hypokalemia exacerbates digoxin toxicity. You need to replete it if necessary. Hyperkalemia is also bad with digoxin toxicity, mostly because it's associated with worse outcomes. Know the potassium and deal with it simultaneously. And last, while you're doing all of that, you can temporize with atropine 0.02 mg/kg up to 0.5 milligrams and repeat as needed, but you really need that digoxin antibody fragment in as soon as possible. If the patient is stable, you can look up the manufacturer's insert and see the formula that you need to use to calculate the Fab fragment dose. There's a lot of math and measuring involved, and I always look it up because we don't see this every day and we shouldn't really rely on our memories. Mostly, to be honest, this is for our older adult patients, but the formula happens to be the same for children, involving the measured serum concentration of digoxin, the patient's weight in kilograms, and that will give you the fraction of the vial to use. If the patient is not doing well, this is not a chronic overdose, and therefore the serum concentration at that point in time doesn't mean anything, or you have no idea how much the patient took, then you need to just treat empirically. In adults, we teach that if this is an acute ingestion and we have no idea how much the patient took, give 10 vials. We really don't know the empiric dose for acute ingestion in children, but we do know that each vial neutralizes about 0.5 milligrams of digoxin. You can always give increments of a vial or repeated vials and watch the heart rate change. So find out what the actual dosage is and do the best you can while you try to figure the rest out. Anyway, not to scare you any further, but the baby was okay for us to wait to measure all of those things: the digoxin, the potassium, the renal function. We were able to calculate a reasonable dose, and she did fine. Digoxin is a drug with a narrow therapeutic index, but it's still a tried and true treatment for chronic congestive heart symptoms in adults and children. But as our colleague from Switzerland, Paracelsus, or Theophrastus von Hohenheim, has been saying for the past 500 Jahre, die Dosis macht das Gift. The dose makes the poison. Wow, that was a lot of low and slow and cold porridge. Let's review the toxidromes that depress your vital signs or sensorium. Cholinergics, like organophosphates or severe nicotine overdose, will give you a wet and depressed dumbbells. diarrhea, urination, meiosis, bradycardia, bronchorrhea, bronchospasm, lacrimation, and salivation. We treat with atropine, and more atropine, and we give enough to clear the secretions, and then we give some more atropine. Calcium channel blockers and beta blockers present similarly, but beta blockers are bitter, and calcium channel blockers are like candy. Both are treated with calcium, glucagon, and maybe some higher level stuff like high-dose insulin and glucose. Sedative hypnotics are mostly supportive care. Don't give flumazenil unless you were the one to make them intoxicated, and even then, let them chill. Alcohol, benzos, barbs, GHB, it's all about watching their airway and letting them metabolize. Less is more. Opioid overdose is mostly supportive. Narcan if critically ill, specifically a severely depressed respiratory drive, apnea, or cardiovascular compromise. Otherwise, you can try small, titrated dosages and even a Narcan drip if needed if the patient is critically ill. Digoxin toxicity can be missed if we don't think about it. If the patient is stable, you can measure the dig level, the potassium, and do your mathemagic to calculate the proper dose of the digoxin-specific antibody fragments. With any of these intoxications, of course, this is only the beginning of how we can safeguard the child. The overdose did not happen in a vacuum, and even if all goes well medically, there's a lot of social splaining to do. Be methodical, be ready, and know when Goldilocks got into some cold porridge. You gotta get things heated up again. And until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.